The next topic we're going to talk about is infarction. And infarction, remember, is when we talked about different types of necrosis, is a reflection of necrosis due to ischemia, lack of blood flow to an area that leads to localized necrosis. What's the necrosis we often associate with this, and the vast majority of tissue in the body is coagulative necrosis, where you have preservation of the architecture of the tissue and what will be lost in this case, when you think of a myocardial infarct, you would see the nuclei being lost and preservation of the structure. And so we talk about this as an infarct. Now, remember, the brain does not contain a lot of fibroblasts, so its extracellular matrix proteins are less of collagen. So therefore, when you have an infarct in the brain, you get liquefactive necrosis. So when we talk about the pathogenesis of infarction, most infarcts are going to, 99% of the time, will result from thrombotic or embolic occlusion of an artery or vein. Because if it's in the vein, obviously, the blood will back up. We have this passive congestion. Depending upon the metabolic state of the cells, those cells, if they require a lot of oxygen, you can lead to an infarct. Other things that can cause an infarct is spontaneous vasospasm that could lead to infarction. If you had torsion of arteries or veins, what's a classic example of this is the testes, since the spermatocord has arteries and veins in there. And if you have torsion or twisting of the testicle, it can, around the spermatocord, what can happen is decreased blood flow and you get infarction of your testes. Factors that predict the development of infarct are the following. Obviously, we go back to all eukaryotic cells are dependent upon oxygen. Some cells in the body are more dependent. So what are some examples that are highly dependent? Obviously neurons, myocardial cells, hepatocytes, tubular cells in the kidney. These are very susceptible to the lack of oxygen leading to infarction. Let's go the opposite. What are some cells that live under low oxygen tension that you would rarely see an infarct? And you think of cartilage, since cartilage gets nutrients by diffusion, so you're not going to see an infarct of the cartilage. Adipocytes are typically under low oxygen tension. Tendons, deep or dense connective tissue, is under low oxygen tension, so you're not going to see infarction there. Obviously, what is the degree of occlusion that's taking place? Is it 5% or is it 100%? And then related back to the vulnerability of that tissue when it's deprived of lack of blood flow of oxygen and nutrients. The rate of occlusion, this is obviously a variable of time. Does it occur in 5 seconds? Over a period of time, you have a thrombus, for example, or an embolus that now will get enlarged as a function of time, and what's the ability of the cells to adapt to it? Then we have to think of infarction. It's important to go back as you study each organ system to go over and review what is the blood supply and how is it provided. So if you have a dual blood supply, like in the lung, we have the bronchial artery and the pulmonary artery. So if you occlude one, you have some blood flow from another vascular source, where you have collateral circulation. Like in the heart, remember the left and right coronary arteries will anastomose at the apex of the heart. And so it's important to know what the microcirculation is and to help you understand how an infarction will evolve based on the microcirculation that's unique to that organ. And then obviously another important factor is the capacity to deliver oxygen to the tissue. And if you have a condition like anemia, decreased blood cell mass, your capacity to deliver oxygen is diminished, and therefore that could also augment or increase the likelihood of an infarction taking place. When we talk about common sites of infarction, when we get to the heart, talk about the most common disease to involve the heart is ischemic heart disease, and part of that, when the heart muscle dies, we call that a myocardial infarct. The brain, infarcts are very common. Lungs, intestines, because remember, the blood supply in the intestines is unique, where the blood vessels are on the outside of the intestine that have to traverse the wall, and the last place to get oxygen along the GI tract is the mucosa, so then you'll get ischemic damage starting there and then traversing to the outside. Kidneys, It requires a lot of oxygen nutrients to maintain its many functions, and it can lead to infarction. What is the gross pathology of infarction? It's wedge-shaped. For those that have never pulled weeds in your life, this is your time to go out and find some weeds. Pull it because it'll help you in the pathology of infarction and explain why it's wedge-shaped. When you pull some type of plant like a weed, you'll see the arborization going in a triangular shape. And so basically the trunk of the main portion of the plant is where if you have an occlusion, everything distal to that will basically go through infarction, and it'll have a wedge shape where the apex of the wedge will point to the proximal nature of the occlusion. There are different colors to infarct. They can be pale or anemic or white. And essentially you think of arterial occlusion where there's a single blood supply like in the spleen or kidney, for example. Also in the heart, but the heart's a little complex because there's collateral circulation occurring in the wall of the heart as well as the apex, but they tend to be pale. So there's no blood flow getting there, and basically the tissue breaks down as the infarction evolves and give you a pale color or white color depending upon the age of the infarct. Hemorrhagic infarcts tend to occur in two scenarios. For example, if you have a thrombus formation in a vein, the blood backs up into the capillary bed of that tissue, oxygenation is decreased, and therefore what happens is that area can go through infarction, and because the vessel walls will infarct as well, you get extravasation into the tissue. In certain organs like the brain where you have an embolic event going to the vessel in the brain, because it has an irregular mass, it can partially occlude it, but enough to have the brain infarct, but then blood can still traverse through it and seep out into the infarcted area, giving you a hemorrhagic infarct. So when we talk about infarction, we have to think of the pathogenesis. We're decreasing blood flow. We call that ischemia, leading to the vast majority of tissues of coagular necrosis. When there's dead tissue, who's first to arrive are acute inflammatory cells. Who's going to follow acute inflammatory cells is going to be macrophages, and who's going to orchestrate the tissue repair process is going to be the macrophage. You get granulation tissue at the edge or the outer part of the infarcted area, and then eventually it'll go from collagen type 3 to a fibrous scar or collagen type 1. So when we talk about infarction, the microscopic features, again, the majority of the organs, what do we think of the necrosis as coagulative? Except the brain, it's liquefactive. And then the general sequence we just went through of infarction.